Products are shown for demonstration purposes only. The AHA does not endorse or recommend any specific manufacturer or product. In order to show skills clearly, the healthcare providers in this video do not always use recommended personal protective equipment, such as gloves. To help improve your assessment skills, the American Heart Association training series includes videos of actual children with medical problems. Of course, at no time was medical care delayed for the purpose of obtaining this video. All children received timely and appropriate medical care, and parents provided consent before recording. As you know, the science of pediatric resuscitation is constantly evolving and improving. In this segment, we'll review the most recent guidelines and recommendations for respiratory and shock emergencies in pediatric CPR. Because of lack of pediatric studies, respiratory rates during pediatric CPR have previously been extrapolated from adult data. New data show that higher ventilation rates, at least 30 breaths per minute in infants younger than 1 year and at least 25 breaths per minute in children 1 year and older, were associated with improved rates of return of spontaneous circulation and survival in cardiac arrest. When providers perform CPR in infants and children with an advanced airway in place, it may be reasonable to target a respiratory rate range of 1 breath every 2 to 3 seconds, or 20 to 30 breaths per minute, accounting for age and clinical condition. It is reasonable to choose cuffed endotracheal tubes over uncuffed for intubating infants and children. When a cuffed ETT is used, attention should be paid to ETT size, position, and cuff inflation pressure. Intubation with a cuffed endotracheal tube can improve capnography and ventilation in patients with poor pulmonary compliance and decrease the need for endotracheal tube changes. 3 systematic reviews of the literature show that cuffed tubes decrease the need for reintubation and improve successful ventilation and the accuracy of capnography. They may also decrease the risk of aspiration. Although cricoid pressure may be useful in certain circumstances, clinical studies show that its routine use reduces the rate of first attempt intubation success because it can impede visualization during laryngoscopy and chest rise with bag mask ventilation. Therefore, routine use of cricoid pressure is not recommended during endotracheal intubation of pediatric patients. The goal of epinephrine administration during CPR is to optimize coronary perfusion pressure and maintain cerebral perfusion pressure. Earlier administration of epinephrine during CPR may increase survival to discharge rates. For pediatric patients in any setting, it is reasonable to administer the initial dose of epinephrine within 5 minutes after the start of chest compressions. For patients with continuous invasive arterial blood pressure monitoring in place at the time of cardiac arrest, it is reasonable for providers to use diastolic blood pressure to assess CPR quality. Although ideal blood pressure targets during CPR are not known, diastolic blood pressure is a marker of adequate blood flow during CPR, and it may be used if an arterial line is in place. Post-cardiac arrest seizures are common. Many are non-convulsive, and they can be detected only with EEG monitoring. When resources are available, continuous electroencephalography monitoring is recommended for detecting seizures after cardiac arrest in patients with persistent EEG. It is recommended to treat clinical seizures that follow cardiac arrest. Previous AHA guidelines for managing septic shock included aggressive fluid boluses, that is 20 milliliters per kilogram, and lacked additional guidance. The 2020 AHA guidelines for cardiopulmonary resuscitation and emergency cardiovascular care suggest a more tailored approach to fluid administration and provide recommendations for vasopressor use. In patients with septic shock, it is reasonable to administer fluid boluses in aliquots of 10 or 20 milliliters per kilogram with frequent reassessment. After every fluid bolus, providers should reassess the patient for fluid responsiveness and signs of volume overload. In infants and children with fluid refractory septic shock, it's reasonable to use either epinephrine or norepinephrine as an initial vasoactive infusion. Pediatric opioid overdose management is the same as it is for adults. For a patient with suspected opioid overdose who has a definite pulse but no normal breathing or is only gasping, it's reasonable for responders to administer intramuscular or intranasal naloxone along with standard basic life support care. This concludes our updates for the science of pediatric resuscitation.